Hello everyone. Today I'm going to speak on the topic behavior management. What is fear? The fear is the reaction to known danger and anxiety is the reaction to unknown danger. There are three types of fear: the innate fear, subjective fear, and objective fear. Innate fear is the fear that results without stimuli or previous experience. For example, fear of predators. The subjective fear is the fear that is transmitted to the individual by the family members or peer groups. For example, when the family members tell you that that is a dangerous place, you shouldn't go there, that type of fear is instilled in the person and it is subjective. Objective fear is the fear due to previous experience or events or objects. So that is, you've been to a place and you already know it's dangerous. So that kind of fear is the objective fear. So coming to the classification of cry by Ellsback. There is the obstinate cry, there is the frightened cry, there is compensatory cry, and there is hurt cry. So you need to know the characteristic features of each type of cry. So the obstinate cry is the type of cry that is characterized by loud, high-pitched, siren-like wail and is often associated with temper tantrums like biting, kicking, etc. Whereas frightened cry is accompanied by torrent of tears with convulsive breath-catching sobs. So it is a genuine type of cry. Here the child is not crying to have his way, but his fear has overcome his reasoning. Then there is the compensatory cry. It is not a cry at all. It is the sound that the child makes with the drill. So when the drilling stops, the child stops crying. There is no tears coming out of the child's eye. Then there's the hurt cry. Initially, the child in discomfort shows a single tear filling in the corner of the eye and it gently moves down the cheek. Actually, there is no resistance to treatment and the patient is not crying at all. The child is simply reacting to the stimulus of pain. So these are the four types of cry: the obstinate cry, frightened cry, compensatory cry, and the hurt cry. Coming to behavior science and its applications in pediatric dentistry. Classification of child's behavior as given by Wilson is that there's a normal child, the anxious child, the hysterical child, and the hurtful, fearful child. So this is the classification given by Wilson. But the most important classification is given by Frankel. So according to the Frankel's behavior rating scale, there is a definitely negative child, positive child, and the definitely positive child. The definitely negative is when the patient refuses the treatment and cries forcefully and shows extreme signs of negatives. Whereas the negative child is reluctant to accept the treatment but exhibits only slight negativity. Whereas the positive child accepts the treatment, but if at all any bad incidents happen during the treatment, the child will become uncooperative. And then there is the definitely positive, where it is a unique behavior where the child understands the need for protective oral health care. So there's a definitely negative, wherein child refuses the treatment and cries forcibly. Then the negative, where the child is reluctant to accept the treatment. Positive, where the child accepts the treatment, but if anything happens during the treatment, child may become uncooperative. Then the definitely positive, which is a very unique behavior. So the maternal attitude can affect the child's behavior. What if the mother is overprotective or over dominant? Then the child can become shy, submissive, or anxious. What if the mother is overindulgent? The child may be aggressive and exhibits temper tantrums. An under affectionate mother can result in a child who is generally well behaved but may cry easily. A rejecting mother may have a child with aggressive, overacting, and disobedient attitude. An authoritative or evasive mother, child may be evasive or dawdling behavior. So, to summarize the maternal attitude and the child's behavior, a mother who is overprotective dominant, the child will be shy, submissive, or anxious. An overindulgent mother, the child may be aggressive, demanding with temper tantrums. An under-affectionate mother, the child will be usually well behaved but may cry easily. The mother is very rejecting, the child may be aggressive, overactive, and disobedient. So if it is an authoritarian mother, then it may be evasive and dawdling behavior may be exhibited by the child. Coming to behavior management. So behavior management is defined as the means by which the dental health team effectively and efficiently performs the dental treatment and thereby instill a positive attitude in the child. This definition was given by Wright in the year 1975. Then there is the behavior shaping or the behavior modification. It is a procedure which slowly develops the behavior by reinforcing a successive approximation of the desired behavior until the desired behavior comes into being. You need to know both the definitions. So, the behavior management can be classified into two broad groups, that is, the non pharmacological approach and the pharmacological approach. Under the non pharmacological approach comes communication, behavior shaping, and behavior management. So, there's the non-pharmacological approach and the pharmacological approach. Under non-pharmacological approach, there is communication, behavior modification, and behavior management. Under the pharmacological approach comes sedation, pre-medication, conscious sedation, and general anesthesia. The communication can be verbal or non-verbal. Behavior shaping is again subclassified into desensitization by Joseph Wolpe, modeling theory by Bandura, and the contingency management. The behavior management includes several factors come under the behavior management, and I have made a short form for you to remember easily, which is ABCHIV, where A is the audio analgesia and aversive conditioning, B is the biofeedback, C is the coping mechanism, H is the hypnosis and humor, I is implosion therapy, and V is voice control. So you can use that code to remember the behavior management techniques. So under the pre-medication, there is sedatives and hypnosis, anti-anxiety drugs and antihistamines come under that. Then conscious sedation and general anesthesia all falls under the pharmacological approach. So the communication can be of two types. It can be a verbal communication or a non-verbal communication. So the verbal communication is best for children greater than 3 years of age. So that way they will understand what we are saying. Then the voice use should be warm, gentle, and a continuous tone. Under non-verbal communication, it includes body languages like smiling, hugging the child, touching the child, eye contact, all comes under non-verbal communication. The next behavior modification techniques include desensitization by Joseph Wolfe. This desensitization is used on children who has had a previous unpleasant experience in the dental clinic. So Joseph Wolfe suggested the use of relaxation techniques like meditation and breathing exercises, and then progressively introducing the threatening stimuli, so that the child has already become tolerant to the threatening stimuli, and their maladaptive behavior will be reduced to a much extent. That is the desensitization by Joseph Wolfe, where relaxation techniques are used. Then there is the Tell-Show 2 technique by Adelson in the year 1959. As the name suggests, tell part includes describing or explaining the procedure simply. Then the show part means demonstrating the procedure to the child, and the do part means perform the procedure exactly as described to the child, so that a sense of trust develops between the child and the dentist. That is the tell, show, do by technique by Adelson. Then there's the modeling theory by Bandura. So allow the child to observe another child who exhibits a positive behavior in a dental treatment. Then we encourage this child to exhibit that similar behavior during the dental treatment. That is, we are using a role model to guide the child to have a positive attitude towards dental treatment. That was the idea of modeling by Bandura. Coming to the contingency management, this is a method to modify the behavior by reinforcing or withdrawal of the reinforcer. So this has two techniques, that's a positive reinforcer and the negative reinforcer. Positive reinforcer is one whose introduction or presentation increases the frequency of the behavior, whereas negative reinforcer is one whose withdrawal increases the frequency of the favorable behavior. That is the contingency management, which includes a positive reinforcer and a negative reinforcer. All this comes under behavior modification. Then discussing the behavior management techniques, like the code that I use, that is the ABC HIV. The first one is the audio analgesia. Audio analgesia, also known as the white noise, it makes use of smooth, harmonious, melodious sound or music in order to calm down the child and to distract the child and hence reduce the reaction to anxiety. Under biofeedback, it involves the use of instruments to physiologically assess the physiological processes like blood pressure inside the body in response to anxiety. In humor helps to elevate the mood of the child and to calm down the child and help to relax the child. So, coping mechanism, the child is a mechanism by which the child copes up with the dental treatment by building a trusting relationship between the child and the dentist. So voice control includes use of one's own voice with a different pitch, frequency or intensity, so that we gain a demand authority over the communication between the child and the dentist. So once we have gained the authority in the communication, the dentist can lower his voice according to the child's activity. But voice control should go in hand with hand over mouth exercise or physical restraints. Then only will it be more effective. Then there is the aversive conditioning theory. The aversive conditioning is the introduction of it can be used for management of Frankel's extremely negative behavior attitude children, because it employs the use of physical restraints, hand over mouth exercise, and hand over mouth and airway restriction exercises. So discussing the aversive conditioning in detail, first one is the hand over mouth exercise. It was introduced by Evangeline Jordan. You have to remember that name, Evangeline Jordan. So it is indicated for children aged 3 to 6 years of age, because that is the age when the children can understand the verbal commands. So it is contraindicated in children under 3 years of age and in medically compromised patients. Then the hand over mouth with airway restriction. So in that, in addition to placing the hand over the mouth, the nostrils are pinched for additional 15 seconds. The idea is that the child has to quiet down in order to breathe, and the siren like wail will decrease to a certain amount in hand over mouth exercise with airway restricted. But all the aversive conditioning techniques require parental consults. Then there is the use of physical restraints. So the physical restraints can be active or passive. Active physical restraints include the dentist aids. Without the aid of a restraining device, the dentist attains the restraining. That is the active method. And passive, the dentist attains the restraining with the aid of the restraining devices. So there are the types of restraining devices for the body involves the pedi-wrap and the papoose board. For the extremities, you can use Velcro straps or posy straps. For the head, you can use head positioning with forearm or body support. And for the mouth, you can use mouth block or mouth props. All these you have to remember, because these were asked several times. For the body, you can use pedi wrap or papoose board. For the extremities, you can use Velcro straps or posy straps. For the head, you can use head positioning with forearm or body support. For the mouth, you can use mouth block or mouth props. Coming to the pharmacologic means of patient management, there is a conscious sedation, deep sedation, general anesthesia, and daycare anesthesia. So, conscious sedation is a minimally depressed level of consciousness wherein the patient can maintain the airway on his own and he or she is able to respond to the verbal and physical stimuli. So, it's a minimally depressed level of consciousness. Whereas in deep sedation, it is a controlled state of consciousness wherein there is partial loss of the protective reflexes, but the patient can purposefully respond to verbal and physical stimuli. In general anesthesia, it is a controlled state of unconsciousness where there is partial or total loss of protective reflexes. The patient cannot maintain the airway on his own and he will not respond to physical or verbal stimuli. Then there's the ambulatory or daycare anesthesia where the patient is discharged on the same day as the treatment. Coming to sedation, its routes and agents. So the most common routes that are used for sedation includes the inhalation route, the oral route, the intramuscular route, and the intravenous route. Most safest route and the efficient route is oral route. So for inhalation, the materials used for conscious sedation may be nitrous oxide, desflurane, and sevoflurane, out of which nitrous oxide you need to remember. On the oral route, the two names that you need to remember is the promethazine and chloral hydrate. For the intramuscular and the intravenous route, you can use midazolam. So some of the side effects of using nitrous oxide include diffusion hypoxia. Now what is diffusion hypoxia? We know that nitrous oxide is 32 times more soluble in blood than oxygen. So because of this more diffusion into the blood, the oxygen carbon dioxide exchange does not take place. As a result, there is a period of transient hypoxia, which is known as diffusion hypoxia. So in order to avoid that situation, the patient should be put on 100% oxygen for 5 minutes after the procedure in order to re-establish that oxygen carbon dioxide exchange. So you have to remember that the consequence, one of the side effects of using nitrous oxide for conscious sedation is diffusion hypoxia. So some other side effects with other gases like promethazine include they cannot be used in patients with sleep apnea. Chlorpromazine is a CNS depressant. Okay, what is a Leydig cocktail? This was asked once. The Leydig cocktail is a combination of promethazine, chloral hydrate, and chlorpromazine. The Leydig cocktail is a combination of promethazine, chloral hydrate, and chlorpromazine. The side effect includes CNS depressant action. So diazepam can cause thrombophlebitis. Midazolam can cause respiratory depression, and barbiturates can cause paradoxical excitation. You have to remember the side effects of some of the gases like uh, nitrous oxide, barbiturates, chlorpromazine. Coming to the stages of anesthesia in sedation, there is plane 1 to 4. So plane 1 is the moderate sedation and analgesia. It is achieved with a concentration of 5 to 25% of nitrous oxide. The effects include mild tingling, mild dizziness and tingling in the tongue, nose, tip of the fingers. There is increased pain threshold and patient will be in a relaxed state. That is plane 1 with moderate sedation and analgesia. Then there is plane 2 with dissociative sedation and analgesia. Here the concentration of nitrous oxide is 25 to 45 percentage. The effects include dissociation or detachment, euphoria, slight humming or buzzing sound, decreased blink rate, but the patient is conscious and is responsive. Plane 3 or total analgesia or anesthesia, wherein the concentration of the nitrous oxide is 45 to 65 percentage. This you have to remember, this concentration of 45 to 65% nitrous oxide can cause amnesia in the patient, but there will be complete analgesia and suitable for extraction. Plane 4 when the concentration exceeds 65 to 85 percentage. Here there is deep anesthesia and the loss of the contact with the patient is lost. These are the stages of anesthesia in sedation. Now let's discuss the questions that were asked in the previous year. The hand over mouth exercise is effective behavioral modification technique in the age group of. I've told you that if we are to use aversive conditioning, the patient should be able to understand what we are saying. So the age in which the verbal commands can be understood is 3 to 6 years of age, because of which that is the answer. The second question, according to Frankel's behavior rating scale, a negative child is the one. We know there are 4 criteria by Frankel's. Frankel's definitely negative, negative, positive, and definitely positive. Definitely negative, the child there is forceful crying, extreme negatives. And the negative, there is reluctance to accept the treatment with slight negativity. So the answer for this is who shows reluctance to accept treatment with some evidence of negative attitude. So IQ 25 to 50 is suggestive of what? We know that IQ less than 25 is suggestive of an idiot. IQ between 25 and 50 is an imbecile. IQ between 50 and 70 is a moron. So the answer for this is imbecile. So paradoxical excitation is caused by, I told you paradoxical excitation is a common side effect of barbiturates. If it were nitrous oxide, you could have said diffusion hypoxia. Nitrous oxide more than 30 to 40 percentage causes. I told you that we have to remember the concentration of nitrous oxide in the different stages of anesthesia. So if the concentration of anesthesia is greater than 40 percentage, if it is between 30 and 40 percentage, the patient can experience amnesia. So we cannot use nitrous oxide in medically compromised patients. That is why the answer for the contradiction for use of nitrous oxide is all of the above. COPD, asthma and sickle cell anemia, we cannot use nitrous oxide. So the answer for this is all of the above. So definition of fear, it is a primary emotion acquired soon after the birth, and it is and so let's just if anxiety is the reaction to unknown danger, fear is the reaction to a known danger, and it is a primary emotion acquired soon after birth. The aim of the first session with the child patient is to all accept. So the first time the child comes to the dental clinic, do not go ahead with the procedure. Make him get used to the surroundings. So we can do communication. We can start obtaining in background information about the child, take radiographs, but do not do the procedure. So the answer for this one is do not start restorative procedures. So coming to tell show do technique of child management. The tell show do technique of child management was introduced by, we know that, Adelson. The tell part means describing the procedure to the child, show part means demonstrating the procedure to the child, and do part means doing the procedure exactly how it was described. So the tell show do technique was introduced by Adelson. Which of the following condition GA and conscious sedation is not required? We use GA and conscious sedation in uncooperative patients, right? So patients with cerebral palsy, mental retardation, emotionally unstable, they will all be uncooperative, and GA and conscious sedation is the only way by which we can achieve anesthesia. But in patients with a controlled epileptic patient where the epilepsy is under control, there's no need for conscious sedation or general anesthesia. A drug which is not used to provide conscious sedation in a child. We know that nitrous oxide is used for conscious sedation, chloral hydrate is used for hydroxyzine is also used for conscious sedation, but lincomycin is an antibiotic. It cannot be used for conscious sedation. So peer pressure. The peer pressure is maximum in which age group? Peer pressure is when the influence of the peer group or the companion friends increases. So this happens in the school time, especially in teenagers. Frankel's behavior rating system does not include the following behavior. We know that the Frankel's behavior rating system consists of definitely negative, negative, positive, and definitely positive. It does not contain indifferent. Next question. Which of the following can be used to calm an anxious child? An anxious child can be calmed by topical anesthetics, passive observer, parents, and child movies being played during the procedure. So the answer for that is all of the above. The office personnel who are at higher risk of nitrous toxicity, the amount of nitrous oxide toxicity can be measured using infrared spectrophotometer. That you have to learn by heart. Infrared spectrophotometer can be used to assess the amount of nitrous oxide toxicity in the office personnel. So home technique, HOMAR and all falls under aversive conditioning techniques. The age of the child considered to be in the pre-cooperative stage of development is 2 years of age. You have to by heart that. That is the pre-cooperative age group. A child whose siblings are also your patients becomes a management problem. What would be your least successful approach? Praise the child, compare the child with other children you have, tell the child how lucky he is to have you as a dentist, place your hand over the child's mouth and speak in a controlled voice. So, a child whose siblings is also your patient. That means that the modeling theory can be used on that patient. Maybe the brother exhibited a good behavior, then the child can be asked to imitate the behavior, but never compare the child with their siblings. That will not help at all. So the answer for that is Compare the child with other children you have. The fear of closed spaces, like dental clinic is called, we know that fear of closed space is called claustrophobia. Whether with dental clinic or any other closed spaces, that fear is called claustrophobia. Nyctophobia is the fear of night. Zoophobia is the fear of animals. And xenophobia is the fear of strangers. The home technique should not be applied to a child who can simply understand simple verbal commands but exhibiting inconceivable behavior, immature frightened child, a 5-year-old child who exhibits hysterical behavior during treatment. So, if the child is an immature frightened child, do not apply the home technique. The term audio analgesia is also known as, I've told you, it is also known as a white noise, wherein a soothing harmonious sound is employed in order to relax the child. When the cry of the child is characterized by a siren-like vocabulary, it is known as the obstinate cry. The characteristic feature of obstinate cry is a high-pitched, loud, siren-like wail associated with temper tantrums like biting, kicking, etc. Question number 27. A child manages an uncooperative child by demonstrating procedures on another cooperative child. The way of child management is called as modeling theory by Bandura, wherein which a child who exhibits a positive attitude in a particular dental treatment is made to be watched by another child so that he is encouraged to imitate the similar behavior. So midazolam dose in children should be 0.1 milligram to per kilogram. This you have to learn by heart. Midazolam dose in children is 0.1 milligram per kilogram. So the another name for stimulus response theory is behavior shaping or behavior modification. Don't forget that, okay? The another name for behavior shaping or behavior modification is stimulus response theory. Question number 31. The fears that are produced by direct physical stimulation of the sense organs are known as. So we know that there are three types of fear. There is the innate fear, objective, and the subjective fear. So innate fear without previous experience of stimuli. Here there is direct physical stimulation of the sensor, because of which this is an objective fear, wherein a previous experience is required. If it was subjective, then it should have been imparted to him by his family members or peers. The fear of a 6-year-old related to dentistry is primarily. So a 6-year-old child who has fear of dentistry is probably because the fear imparted to him by the members of the family or his peer friends. So it is subjective. So coming number 32, a child who has to be given pre-medication for behavior modification, which is the most preferred route. The most preferred route for all for medication is the oral route in children. Fear of strangers and fear of separation from parents will diminish by the third birthday. You have to learn that by heart. Fear of the strangers and fear of separation from parents will diminish by the third birthday. If the use of technique on a child is objectionable enough that the child will cooperate in order to avoid it, that technique will come under aversive domain. So Joseph Wolpe developed the following technique. So desensitization was developed by Joseph Wolpe, which included the use of relaxation techniques like uh, breathing exercises and meditation in order to make the child more tolerant to aversive conditions. Whistle is a word substitute for explaining the following instrument in children. Whistle is the word substitute that we use for high-speed handpieces. The first book on child dentistry was published by Joseph Hurlock. Learn that name by heart. The first book on child dentistry was published by Joseph Hurlock. A mother who does not encourage her child to cope up with new situations, thereby making him shy and timid, is an example of. So this is an example of an overprotective mother. As a result, the child becomes timid and shy. The art of reinforcing good behavior displayed by the child with verbal praise applies to operant condition theory. So, an effective state of consciousness in which joy, sorrow, fear, hate, or the likes are expressed is known as emotions. So, this is the conclusion of that chapter. I'm sorry, there's one more. No, this is the conclusion of that chapter. Thank you for your listening.